I'm going to get started just so that we have time to kind of get through everything I was hoping to accomplish today. I want to start by introducing myself. My name is Michelle Musil-Moons. I'm one of the IBD physicians at the University of Michigan Health West. That's the University of Michigan site in Grand Rapids, formerly known as Metro Health, Metro West. We've had a couple names, but this is our most recent name, is University of Michigan Health West. I actually was at the IBD Center in Ann Arbor at the University of Michigan main campus for about 10 years, and recently, just around the time of the pandemic, moved out to Grand Rapids to try and serve the IBD population in West Michigan. I am incredibly passionate about engaging patients in decision-making about their care. And one of the most important parts of that is making sure patients feel informed enough to participate in that decision-making. So my goal today was to kind of give you a brief introduction to what I give patients on their first visit, so that I hopefully give you some kind of empowerment to help engage with your doctor in terms of talking about your care and decision-making about medications and treatment plans, okay? I am trained as a gastroenterologist, an IBD physician, and an immunologist. And I always start out by saying I always apologize to the immune system, because I'm going to simplify it down to the stage where I feel comfortable that everybody can be on the same page. Doesn't mean the immune system is not the beautiful, complicated system that it is in real life, but I'm going to talk about it, just the pieces that I think we need to understand decision making. So inflammatory bowel disease, as you're aware, affects over 3 million people in the United States. Its prevalence is a little over 1%. There's traditionally 3 flavors of inflammatory bowel disease, and this is constantly evolving as we learn more about the disease process and what causes it. So some of it's called Crohn's disease, some of it's called ulcerative colitis. We used to have a term called indeterminate colitis when we didn't know if people were Crohn's or ulcerative colitis, which, by the way, many of us don't use anymore because the insurance companies decided they didn't like that term. And so you may have indeterminate colitis, but your doctor may have been forced to choose a label. Doesn't mean we don't know what's going on. It just means you were probably in that gray area where we didn't know which label worked best, and we had to pick one in order to get you on treatment. It equally affects men and women. It has this very unique bimodal age distribution. So we talk about the PEDS group, and there's people that are usually diagnosed in their early or mid-adolescence, and then there's sort of a lull in new diagnoses. Some people are diagnosed throughout adulthood, and then there's a big peak in the 50s and 60 range. And we don't exactly know why all that happens, but we do recognize that over time. And I want to reiterate that IBD, both Crohn's disease and ulcerative colitis, are now well recognized as chronic, lifelong diseases. So even if we get patients into remission, I remind them that that's always going to be a disease they carry, but the goal is to get it well managed and into remission. So as Dr. DeFelice very elegantly talked about, we try and treat to a target of remission with normal bowel function, relief of clinical symptoms, and re-engagement in life so you can achieve all your life goals. Because that, you know, we talk about all the details of IBD, but every IBD physician you're going to meet went into medicine to help you feel better. That is the overarching goal of why people go into this. And so while we strive to improve clinical symptoms, we also want to make sure you're able to engage in your life and have good quality of life. So the million-dollar question, what causes IBD? There is a ton of literature on this. We're learning more and more every year, partly funded by studies from CCFA, partly from a whole bunch of studies across the nation and around the world trying to figure out what triggers IBD. The bottom line is we don't know exactly, but we have a lot of things that point towards a very complex relationship between the genetics, the microbiome, which are the bacteria that live in your colon and are supposed to live there to help you digest things, and then the environment around you, the medications, the foods, the chemicals, the everything in your environment. We know that there are some risk factors: age, race, ethnicity, family history, smoking, some medication exposures, urban environments, diet, but we don't exactly know how each of those risk factors trigger disease. So it's very hard to counsel patients that, oh yeah, we're learning a whole bunch. We know 150 different genes that are associated with Crohn's and ulcerative colitis, but we don't know exactly how it's triggered, so we can't tell patients how to predict or how to guide prognosis based on what we know so far. So briefly, IBD pathology, and you'll see this in like all these different presentations, but I like to go down just to the basics. The top picture is a healthy colon biopsy. It's beautiful. It's very structured, nice columns, a little bit of white with some purple speckled in it. My husband's a pathologist. He hates when I talk like this, but that's what a good biopsy should look like. White with some pink lines and purple speckles. On the bottom is a biopsy of a Crohn's patient. And you can see across that entire surface, you lose those beautiful little columns. You get way more purple than you need there. Purple are immune cells, okay? Purple are immune cells that are in the lining of the colon that normally should be there, but in much smaller numbers. I talk about this in clinic about immune cell parties. Immune cells are born out of your bone marrow, and then they go find a home somewhere in your body, okay? Many immune cells live all throughout your body. Your skin is a huge immune organ. Cells are born, they go out to your skin, they become a specialized skin immune cell. Other immune cells are born, they go to your liver, they become a liver immune cell. And there's a ton of cells that make their home in your colon. And most of the time, they're really well behaved. Look at these teenagers with their party hats taking a selfie. Really well behaved immune cells doing their job, taking care of the lining of your colon or your intestinal tract. However, in patients who have inflammatory bowel disease, whatever flavor they have, it's generally because the immune cells that are trying to do a good job to take care of you have a party and it gets out of control. It's more like these partiers, where instead of really well behaved and taking selfies and then going home at the end of the night, you can imagine that this, whatever it is, bar, party, house, whatever it is, was a little bit destroyed when this group left. And that's essentially what's happening to the lining of your colon or your intestine when we finally start to turn those immune cells down and get the party to calm down. There's a big cleanup that happens afterwards, all right? But the goal is to get us to a point where your body can start working on cleaning up after the party instead of generating more problems. Jane Austen once said, one cannot have too large a party, and I would argue that with immune cells, that's not true. People with inflammatory bowel disease definitely have an immune cell party that is too large. And I'm going to take that analogy and talk about damage to the colon and how we treat these diseases using that analogy. Because all the medicines we heard Dr. Cohen talk about this morning at the first joint session are fantastic. But we need to understand exactly how they work so that you can help your doctor figure out which one's the best for you. So ulcerative colitis is this superficial inflammation along the colon. By definition, it's limited to the colon. We know that ulcerative colitis affects other parts of your body, but the inflammation of the GI tract is limited to the colon. It can be somewhat limited or be proctitis, just kind of at the rectum area. It can be left-sided colitis, and it can be pancolitis or the entire colon. And your doctor uses these different terms to kind of figure out severity, what medicines would be best for you. For patients, I tell them where your disease affects you also changes how your symptoms look to you, too. The most troubling or disturbing symptoms for patients, that urgency or bleeding or tenesmus, the needing to go to the bathroom, but not knowing if you actually need to have a bowel movement. You don't know exactly what's going to happen when you're there. That's tenesmus. And these are all symptoms that are generated from inflammation towards the end of the colon, the left-sided and specifically the rectum. Distal inflammation is responsible for those symptoms, and most of the time patients experience urgency, frequency, and this tenesmus. And when they do a colonoscopy, I hope your doctors are able to show you the pictures they take so you can compare them over the years before treatment and after treatment. But the far left side is a healthy, beautiful colon. Oh, that's gorgeous. Beautiful blood vessels, nice, shiny surface. Beautiful clean out, by the way. The second one is kind of moderate disease. I would probably call that moderate to severe. Lots of ulceration, exudate. There's like lots of things going on there. And the far right is severe for sure. Little deep ulcerations, very inflamed. And I'm sure many of you have brought home pictures of your colonoscopy and say, oh, that probably isn't normal. But they may not have given you a normal to look at or a goal to try and achieve. Diagnosis is the mainstay of diagnosis is biopsy, and I tell everybody sometimes you'll see hints of disease on imaging, but really to nail down that initial diagnosis of a lifelong disease, you're going to want to be sure with histology. Crohn's disease, we heard about it earlier. It's a little bit different. It can affect the entire GI tract, including the small bowel. I used to call it the black box of the GI system, right? An EGD can get down to your stomach in the first part of the small bowel. A colon can do your whole your colonoscopy can do your whole colon in the last part of the small bowel. It's very difficult to get a view of the entire small bowel. And there's a lot of intestine in there that is really important for absorption, important for nutrient processing. Again, on the top, that's the same happy normal colon. In the middle, colonoscopies for people with Crohn's look a little different, right? You can see in this middle one, on the upper left part of that picture, there's a little hint of normal colon, and then a very abnormal area in the center. Very nodular and bumpy, sometimes with fistulas, sometimes with a bad ulcer, and then normal-looking shiny colon around it. That's kind of characteristic of Crohn's, where it's not the whole colon involved, it's sort of patchy involvement. I always tell patients, if you've had GI symptoms for a long time and people thought, oh, nothing's wrong, remember that Crohn's patients often go years, either asymptomatic or minimal symptoms before they're diagnosed, okay? It's not in your head. You're not crazy. You may have been said, oh, you probably have IBS, which statistically is likely true. Many Crohn's patients over the years then get that formal diagnosis, get the biopsies to show they have active disease, and then have you may have had some IBS symptoms, but now we have an inflammatory target that we really need to treat. Diarrhea is a predominant symptom as well as abdominal pain for Crohn's disease, but they're not the only symptoms. And patients can have Crohn's disease without diarrhea. I know, blasphemous, right? If you have predominantly small bowel Crohn's, but your colon is really healthy, you probably won't have a lot of diarrhea, but you can still have a lot of disease symptoms. Diagnosis, like I mentioned, imaging can help us, but scopes are going to be the mainstay with biopsies to help confirm that. I want to spend a second talking about when you meet with your doctor, we talk a lot about how many bowel movements are you having, how are you feeling, how often are you going to the bathroom, is there blood present, what does it look like, what's the form? It's really important for us to kind of get a sense of how you're doing clinically, but then there are other parts of your body that can be involved, in particularly Crohn's disease, but also ulcerative colitis, okay? One is extraintestinal manifestations of these diseases, okay? You can have sleep disturbances, skin changes, skin rashes, eczema, psoriasis. All these skin issues are more common in patients who have IBD. Kidney stones are more common in patients who have Crohn's disease. I ask every patient, do you have a history of kidney stones? It's amazing how many new diagnosis patients have had a history of kidney stones over their life. Musculoskeletal issues, particularly if patients have had a lot of steroid exposure. Vitamin deficiencies, vitamin D deficiencies, B12 deficiencies. You need a healthy gut to absorb all of these small micronutrients. Vascular issues, people who have had chronic blood clots because of active inflammation. A lot of times I'll have to ask them about that history and try and figure out if there's a correlation. There is overlap of autoimmune diseases in the liver as well as in the gut. So some people will have autoimmune diseases affecting both. And then I ask every patient about eye changes because inflammation in your body can affect your eyes, causing inflammatory issues in your eyes. And it's important for some of them to be caught and treated early. So I want to go back to why do we treat IBD? I have some patients who have minimal symptoms. Why do I have to treat this? Well, the number one thing is we want to get you feeling better, right? We want to get you out of the restroom so you're living most of your life in the real world, not in the bathroom. But we also want to make sure we avoid complications. So as Dr. DeFelice showed you on that initial plot where it's like this kind of scale of accumulating bowel injury, complications of ulcerative colitis and Crohn's disease can be devastating to patients, and they can come on after years of mild to minimal symptoms that maybe kind of flew under the radar. So in ulcerative colitis, recurrent flares, of course, are a problem, and those tend to come to attention early. But things like C. diff infections, CMV colitis, dysplasia or precancerous changes in the colon, which can increase your risk of colon cancer, are all complications of ongoing inflammation in the colon, and one of the reasons we really want to target treatment. Similarly, for Crohn's, you have the risks of inflammation, but you also have the additional risks of that transmural or full thickness inflammation with fistulas or infections, abscesses, other kinds of complications of ongoing disease. So we want to avoid these, okay? We talk about their presence. We know they happen to patients, but the goal is to get you on treatment so you don't have to deal with these. So I want to come back to the immune system. It's such a beautiful, you see these pictures, right? It's so complex. It's so gorgeous. These are the cells interacting at the mucosal surface to keep you safe. But it's really hard to understand when you look at a picture like that. So I always say, okay, our goal is to stop and shut down this party when it gets out of hand and only keep the party at the level you need to be safe. So Dr. Cohen gave a beautiful history of the treatment of IBD, and I wanted to bring that back and talk about what it means for your immune cell party, okay? So if you have this party of pink and purple speckled cells on your biopsies, and it's a little too active and your immune cells are too excited, there are a bunch of medicines we've used over the years to try and get that under better control. So we all know that steroids has been the mainstay for decades, although they're not safe and not good maintenance therapy. But the way steroids work is they basically are a stun gun for all the immune cells. And it's part of the reason when you're on steroids, your risk of infection is so high because all the immune cells across your entire body are stunned. They're not really sure what to do. Steroids are a general immunosuppressant that just holds everything in place. If you think about that immune cell party, the problem with that is it stuns the party. They kind of sit around and look at each other, but they don't necessarily go away. And as soon as you take away the steroids and you take away the stun, the immune cells wake right back up and do what they're supposed to do. That's an simplification, but that's essentially what happens when you take away the steroids for most patients. So that's why we try and get more targeted therapies. We talked a little bit about the 5-ASAs earlier, not great for Crohn's because essentially they're like spraying a water hose on the surface of the colon. And I talk about this in the party scenario, right? If you spray a water hose on the party, some of the party goers might get a little upset and go home, but the people inside the house, the people that are still partying, many of them won't go home. So for mild disease, it works well, but for deep-seated disease, sometimes it's not enough. So the next mainstay are the anti-TNFs, and this is when we start getting into the nitty-gritty of what's the best medication for each patient. So the anti-TNF therapies are essentially medicines that you take either by IV or injection to calm down the immune cell party. And the way it works is the medicine is essentially a little blocker for the little chemical invitations that are coming out of the immune cell party. I think about this as a group of teenagers, not because I have teenagers, but I just think of them as rowdy. And I think about them sending out little social invitations, Facebook, Instagram, Snapchat. I'm totally dating myself, but they send out little social invitations. I think of those as the TNF molecules. Social invitations to bring fresh new immune cells to the party, to keep replenishing the party so that you can continue to have active inflammation, because that's what the immune cells mistakenly think you need. The anti-TNFs go in and they block some of those chemical invitations, inviting fewer cells to the party, and so that your body can start to calm down that party, shrink it down to a more normal size, and get you back to normal appearing colon or intestine. So these are little chemical invitation blockers, okay? They work really well. They've completely changed how we treat IBD for patients because they're able to calm the party down and in many cases get people back to normal intestine and colon. Then came the antiintegrins. The antiintegrins are like vedolizumab. They're biologics. They have to be infused in the vein. I'm going to back up for a second. Many of the anti-TNFs have to be either injected or infused. A lot of patients ask me, why can't I just take these as a tablet? All right? And that's because the way these medicines were designed, the way they block the immune cell party invitations, if you took it by tablet, your stomach would digest it and destroy it. So we would love to make it in tablet form, but we haven't figured out a way to make these type of chemicals, monoclonal antibodies, into ingestible forms. So instead of ingesting, we put them right in the bloodstream. So we deliver the invitation blockers right to where you need them. They float around and they sort of block the invitation so things don't know how to get to the active party. Vedolizumab said, okay, well, what if we just block the active party at the colon or the intestine? All right, so what this chemical does is it goes in and it says, okay, there's a big immune cell party in the colon. A bunch of fresh immune cells are grabbing invitations and going to this party. Is there any way we can block them from getting there? And vedolizumab goes and puts a barrier at the entrance from the bloodstream to the colon. It says, we don't need any more active immune cells here. If you have an invitation, go find a party somewhere else. Go see if there's a scratch on the skin you can fix, or go see if there's something going on in the lung that you can fix. We don't need you in the colon right now. And of course, it's not 100% barricade. Everybody's been to a big march or a big party where a bunch of people go around the barricades, so it's not 100% fix, but it certainly provides a different way of addressing how many cells are getting into that area and causing trouble in the lining of the colon. A couple of the new small molecules that we talked about earlier have come out in order to sort of augment or give us other options for treating disease. We talked a little bit about Anamod earlier. You may even remember this from Dr. Cohen's slide. We always show the lymph node and a big X on it. The way Anamod works is it's a tablet. It goes, and any active T cells that go into the lymph node near your site of the immune cell party kind of blocks them there and says, we're going to hold you here. It's kind of like the holding pen at big concerts when people are in trouble and the security forces sort of push them there, holds them there for a bit. Says, stay there for a while because we don't want you on the main floor. You're causing too much trouble. Maybe that was only when I was young. I don't even know if they do that anymore. But I distinctly remember the holding pens. That's what this medicine tries to do to the active T cells. So that active T cell can't go up to the immune cell party, perpetuate that inflammation. So Dr. DeFelice did such a really nice job of talking treat to target. And I wanted to just kind of roll it back a little bit and talk about, when she talked about the objective markers of disease activity, what exactly are those markers and when should we be using them? So a lot of people are probably familiar with this, but it's amazing how many people come to my clinic and they have no idea what CRP or fecal calprotectin are, okay? They may say, oh, I gave my doctor a bunch of stool. I'm sure they tested for that. I'll be honest, in primary care and in the community, most people will do a stool test for things called looking for white blood cells in the stool, looking for immune cells in the stool, looking for infection in the stool, culturing the stool. I will tell you, not a lot of that is really useful to your IBD doctor. It's interesting if it's positive, but it's almost never positive, okay? What's more interesting are some of the objective markers we can use that give us that scale of this is really inflamed, this is better, this is much improved. And the two things that have been shown to be able to do that, to track over time, is C-reactive protein. C-reactive protein is a molecule in your bloodstream. Everybody has it. When you get inflammation anywhere in your body bumps up your CRP until your body sort of calms down and the inflammation improves, and then it comes back down. So CRP in your bloodstream, on your blood work, can be elevated because your colon is inflamed, because your small bowel is inflamed. It can be elevated because your joints are inflamed. It can be elevated because you have a pneumonia. Maybe you have an abscess or an infection. Maybe you have an ear infection. Maybe you had COVID 2 weeks ago. Your CRP can go up for a lot of reasons that are not related to a flare, but it can also go up related to a flare, okay? A little bit more specific is the stool test called calprotectin or fecal calprotectin or FCP. There's a lot of different abbreviations for it. Essentially what that does is we get a little bit of stool, like Dr. DeFelice said. I send tons of stool cups home with my patients, just put them in the cupboard. Bring your stool in, we test it. We're not looking for blood, although blood definitely is a sign that your number might be high. We're looking for a protein that when you have ulcers in your colon, that protein leaks into your stool. When you don't have ulcers, the protein doesn't leak. So when you don't have ulcers, your fecal calprotectin is really low, sometimes undetectable. And when you have active disease, you leak that protein into the stool, and that's how we can detect it. It's a very elegant way of saying this inflammation is present, and it's because of the intestine. For years, I practiced using CRP, and I couldn't guarantee patients that their CRP was high because of their intestine. So what did we have to do? I'd say, I think you have inflammation somewhere. Now I have to do a scope and see if it's your colon. But now I can say, I think you have inflammation somewhere. Why don't you give me some stool and we'll see if it's your colon. It dramatically decreased how many times patients had to prep for a colonoscopy. It doesn't make it zero, right? We want to make sure people are healing, but I do a lot fewer colonoscopies per patient than I ever did. And then, of course, we talk about treating to target. My doctor target is good CRP, good fecal calprotectin. We're doing a good job. But I always have to remember at the end of the visit to say, what's your personal goal? Did you go on that trip you wanted to? When you went on that trip, did you have to stay at the hotel because you had to use the bathroom so often? Or were you actually able to go do what you wanted to do? And those are the goals we have to remember to set for patients, because that's how they'll realize that they are improving, even though it's a slow improvement, and day to day that can be imperceptible. So I wanted to close by letting people know that I talk to patients a lot about how I'm going to be really deep in the numbers. I'm going to want to see if your calprotectin's improving. I'm going to want to see if your colon's improving on scopes. But I want to make sure also that your symptoms are improving and that your long-term goals are being met. So that requires a partnership, which is really unique to IBD. There are only a few other chronic conditions where you get to partner with a doctor so completely, right? Where you get to see that doctor regularly. I see some of my patients more than they see their primary doctor because we're trying to get their disease under control. So partner with your doctor, ask the questions. If you don't know why they're doing something, don't be afraid to ask. Because if you're informed, you can turn around and probably enlighten your doctor and say, well, that's great, but that's not gonna work for me because I have a cost accumulator and I can't get on ustekinumab, or because every time I take my stool and I have trouble because I can't get the cup, or I can't take it to the right place, or I don't have the order, or they didn't fax it, or whatever barrier you're having, that being in good communication with your doctor will help you to overcome that. That's the end of my prepared slides, and I should check my time. I think we have like 1 or 2 minutes. We're gonna have a big panel for questions. I don't want anybody to ever feel like a question is too basic or too IBD 101. So I want to give a couple seconds here. Does anybody have any questions that they want to ask, knowing that everybody here is trying to get on the same first page? That's a really good question. So when we first came up with she asked, is a normal calprotectin for an IBD patient the same as a normal calprotectin for an average person without IBD? And then what do we consider normal? When we first came up with this test, we were able to say elevated and not elevated, undetectable and elevated, and we set kind of this normal goal. And then we have a bunch of different versions of the test where normal might be less than 25 or normal might be less than 100. So there's a couple different tests now. So the actual number might be variable. What I tell patients is we need to set a goal. So if my patient that I meet has an initial fecal calprotectin of 1,200, it's impressive, high. I say, listen, my goal for you is to get your fecal calprotectin below 500 by this date and below 150 by this date. Now, 112 will probably still register as elevated. But if I have a patient who is at 1,200, their symptoms and their bowel look pretty good if they're down around 100. So the bottom line is it's probably a little different for everyone, and every doctor probably uses the goal a little different. I definitely have patients where I say, my goal for you is completely normal calprotectin in a year. I want it to be undetectable. I also have patients where I don't think that's realistic. And I say, my goal for you is a fecal calprotectin below 150 on therapy. And so you have to vary it based on how your patient's doing, the severity of their disease, what they've responded to in the past, and sometimes how their scope looked. Did that answer your question? On average, the normal is the same if you have IBD or you don't. So if I tested everybody in full remission, should look like somebody who doesn't have IBD. But a normal fecal calprotectin is a pretty strong goal, aspirational goal, I tell my patients. So kind of set some goals before that, which still shows reasonable control.